Hello. So this is the start of cardiovascular system lectures with congenital heart disease. Congenital heart disease is actually a general term designating abnormalities of the heart or blood vessels that are present at birth. And most of them arises from faulty embryogenesis during gestational weeks 3 through 8, when major cardiovascular structures form and begin to function, and the most severe anomalies are incompatible with intrauterine survival, and significant heart malformations are common among premature infant and stillbirths. On the other hand, defects that affect individual chambers or discrete regions of the heart are often compatible with embryologic maturation and eventual live birth. So this is normal fetal circulation. Umbilical vein supplies the oxygenated blood. There is patent foramen oval. Patent foramen oval. Foramen oval is actually an opening in between the right and left atrium. Ductus arteriosus is a connection between pulmonary artery and aorta. So patent ductus arteriosus and foramen oval ultimately is responsible for supply of the oxygenated blood to the body. So in the fetus, oxygenated blood from the placenta goes into the inferior vena cava, then through the right atrium into the right ventricle in the pulmonary artery, and from pulmonary artery via patent ductus arteriosus into the aorta, and it supplies the lower extremities. And from the right atria through the foramen oval, the oxygenated blood goes into the left atrium, left ventricle, aorta, head and neck, and returns via the superior vena cava. So what happens after birth? The transformation from fetal to neonatal circulation begins with the two major changes. One, a marked increase in the systemic resistance caused by loss of the low resistance placenta, and marked decrease in the pulmonary resistance, marked increase in the systemic resistance, and marked decrease in the pulmonary resistance, that is caused by the pulmonary artery dilatation with the neonate's first breath. So this is fetal circulation with patent foramen oval, patent ductus arteriosus. This is circulation in 8 hours old infant. Foramen oval is closed here. Ductus arteriosus is about to close. And during 24 to 72 hours after birth, ductus arteriosus closes and circulation is almost of an adult. Foramen oval is closed and ductus arteriosus is also closed. These are different congenital heart defects. Most common is ventricular septal defect, which is a cause of left to right shunt. Second most common is atrial septal defect. So out of 100% congenital heart defects, 42% is occupied by the ventricular septal defect. Second most common is atrial septal defect with 10%, pulmonary stenosis 8%, which is actually an outflow obstruction. Atrial septal defect is in the left to right shunt. Patent ductus arteriosus 7%. Fourth most common is also a cause of left to right shunt. Tetralogy of Fallot, fifth most common. Then coarctation of the aorta, atrioventricular septal defect, atrioventricular septal defect, aortic stenosis, outflow obstruction, transposition of the great arteries, truncus arteriosus, total anomalous pulmonary venous connection, and tricuspid atresia. Incidence of the congenital heart defect is up to 5% of all births, and these are among the most prevalent birth defects, and approximately 1% of individuals have significant forms of congenital heart diseases and are diagnosed in the first year of life itself. And milder forms of these congenital heart diseases sometimes may not become evident until adulthood. And with the advances in therapy, nowadays number of individuals who survive into adulthood is increasing. So this is how the heart is formed intrauterine. Embryological development of heart. This emphasizes three main sources of cells: normal, human, cardiac development. So there is a first heart field shown here with red and pink color. Second heart field is yellowish in color, yellow colored. This is first heart field template at about day 15 intrauterine. This is second heart field migration at about day 21 intrauterine. This is neural crest migration at about day 28. And complete formation of the four-chambered heart at about 50th day. So surgical advances, more thanks to the surgical advances, the number of patients surviving with the congenital heart disease is increasing. But the repaired heart may not be completely normal even after surgery, since the myocardial hypertrophy and cardiac remodeling brought about by the congenital defect may be irreversible. In addition, virtually all cardiac surgery results in some degree of myocardial scarring, and secondarily arrhythmias, ischemia, myocardial dysfunction occasionally may appear years after the surgical correction. So most instances, the pathogenesis of this congenital heart disease is actually from faulty embryogenesis, and in almost 90% of cases the cause is unknown. Most of the etiological factors are sporadic: genetic abnormalities, environmental factors, congenital rubella infections, teratogens, maternal diabetes. Clinical features of congenital heart disease. So, clinically, these are classified into three different congenital heart disease. Three different parts. One is malformations causing a left to right shunt, malformations causing a right to left shunt, which is also known as cyanotic congenital heart diseases, and malformations causing obstructive heart disease. Right to left shunts are associated with cyanosis, but left to right shunts initially are not associated with cyanosis, but with time they expose the low pressure, low resistance pulmonary circulation to increased pressure and volume, and this lead to adaptive changes, increased lung vascular resistance, resulting in the right ventricular hypertrophy and eventually failure of the right ventricle, right ventricular failure. And with time, the increased pulmonary resistance and right ventricular hypertrophy causes shunt reversal from left to right shunt to right to left shunt, and late onset cyanosis is also there in left to right shunts. And these are the third types of anomalies: obstructive heart diseases, obstruction in the chambers, walls or blood vessels. If a complete obstruction is there, then it is known as atresia. Now left to right shunts. So left to right shunts, the causes of left to right shunts are atrial septal defects, ventricular septal defects and patent ductus arteriosus. Cyanosis is not an early feature but is a feature on a long term of left to right shunts causes. And when left to right shunt is converted into right to left shunt, it is known as Eisenmenger syndrome, reversal of flow and shunting of unoxygenated blood into the systemic circulation. So this is atrial septal defect. So they are abnormal fixed openings in the atrial septum caused by incomplete tissue formation that allows communication of blood between the left and right atria, and they are usually asymptomatic until adulthood. Ventricular septal defect and patent ductus arteriosus. These both cause increased pulmonary blood flows as well as increased pulmonary blood pressure. But atrial septal defect only causes increased in the outflow volumes. Atrial septal defects are classified according to their location. Secondum ASD is the most common type of ASD, 90% of all ASD is of secondum ASD type. Second type is primum anomalies, and third is sinus venosus defects.
Before birth, it is normal to have an opening called the patent foramen ovale in this wall. This opening usually closes shortly after birth. Sometimes the wall between the chambers doesn't develop completely. As a result, an abnormal hole called an atrial septal defect is left in the middle of the wall. This opening allows blood to move between the upper chambers, which increases blood flow to the lungs. If the hole is large enough, the increased blood flow leads to enlargement of the heart and can also damage the blood vessels in the lungs. It can also lead to abnormal heart rhythm due to injury to the heart muscle. Most children do not have symptoms, but those with a large defect can have slow growth and rarely a condition called congestive heart failure. Treatments for ASD may include medications for symptoms, but the definitive treatment is closure by either cardiac catheterization or surgery. If the hole is large or hasn't closed by age 2 to 5 years, a catheter or surgical procedure may be necessary. During a catheter procedure, a tube called a catheter is inserted through a small incision in the child's groin. From there, the catheter will be threaded through blood vessels to the child's heart. Next, the doctor will place a device called an atrial septal occluder across the defect to plug the hole. The device will stay in the heart and prevent blood from crossing between the upper chambers. Then, the catheter will be removed from the body. When the hole is too big or when there is no place to attach the device, open heart surgery is necessary to close the hole. To begin, the surgeon will make an incision in the chest. Once the heart is reached, the hole will be closed with a patch. The incision will be closed and covered with sterile dressings. Our Heart Center team at Nationwide Children's is dedicated to supporting your child. We are available to answer.
So these are few points about atrial septal defects, a video of atrial septal defect with the management part. Now ventricular septal defects, these are classified according to their size and location. One is membranous ventricular septal defect, second is infundibular ventricular septal defect. Now if ventricular septal defect is detected in the pediatric age group, it is associated with other congenital cardiac anomalies like tetralogy of Fallot, and if it is first detected in the adult, then it is an isolated anomaly most of the time. So this is a picture of ventricular septal defect which causes left to right shunt initially. Supracrystal, membranous and muscular type of ventricular septal defect in the figure. Most small VSDs are asymptomatic and detected only in the adulthood. Chest X-ray, cardiomegaly and increased pulmonary vascular markings in a pediatric age group. Third type of left to right shunt is patent ductus arteriosus. Third common cause of left to right shunt is patent ductus arteriosus. So the role of ductus arteriosus is during intrauterine life, it permits blood flow from the pulmonary artery to the aorta. So it bypasses the unoxygenated lungs. After birth in healthy term infants, the ductus constricts and functionally closed after 1 to 2 days. Complete obliteration occurs within the first few months of extrauterine life, leaving only a strand of fibrous tissue and is called as ligamentum arteriosum. So blood is pumped at high pressure through the PDA. The lining of the pulmonary artery will become irritated and inflamed if patent ductus arteriosus is there. So there are chances of bacterial endocarditis with patent ductus arteriosus. Clinically, it causes characteristic machinery-like murmurs. Now, second type of congenital heart defects are right to left shunt type, and as the unoxygenated blood goes to the left side, so cyanosis is there. Tetralogy of Fallot is the most common cause of right to left shunts, and the tetralogy here is ventricular septal defect, right ventricular outflow tract obstruction by subpulmonic stenosis, overriding of the aorta, overriding the ventricular septal defect, and fourth is right ventricular hypertrophy. Morphologically, the heart is enlarged and boot shaped, and also right ventricular hypertrophy is there. Clinically, even untreated, the patients usually survive into the adult life. 10% of untreated patients are alive at 20 years and 3% survive up to 40 years. Initially, there is if subpulmonic stenosis is mild, the abnormality resembles an isolated ventricular septal defect and shunt may be left to right. But if subpulmonic stenosis is severe, then from the initial time the shunt is right to left. Clinical presentation: cyanosis, irritability, lethargy, reduced physical activity, fainting, clubbing of the nails, fingers and breathing difficulty. So this is a video of tetralogy of Fallot,
called the ventricles. The hole allows oxygen-rich blood to mix with oxygen-poor blood. Normally, the aorta attaches to the left ventricle, which pumps oxygen-rich blood through it. In an overriding aorta, the aorta has moved forward directly over the hole between the ventricles. This allows oxygen-poor blood from the right ventricle to flow into the aorta. Pulmonary stenosis means that the blood vessel going to the lungs, called the pulmonary artery, is narrowed, and the pulmonary valve doesn't open all the way. As a result, less blood reaches the lungs. These heart problems cause the baby to be blue because the heart pumps less oxygen-rich blood to the body. Right ventricular hypertrophy means the wall of the right ventricle is thicker than normal. This happens because the right ventricle has to work harder to pump blood through the narrowed pulmonary valve. Treatment for tetralogy of Fallot may include temporary and complete surgical repair procedures. Sometimes a child is not ready for a complete repair right away. In this case, a temporary repair called a shunt can be placed until a complete repair can be done. The shunt improves oxygen levels in the blood. During this procedure, the surgeon will place a tube called a shunt between a branch of the aorta and the right pulmonary artery. The shunt will provide another path for blood to get to the lungs to pick up oxygen. Instead of a shunt, another temporary procedure can be done. In this procedure, a device called a stent is placed in the narrow area to allow more blood to flow to the lungs. Most patients have a complete repair at 4 to 6 months of age. If the main pulmonary artery is too small, it will be widened with a patch. If the pulmonary valve is too small, it may be widened with a patch called a transannular patch. If the narrowing is below the pulmonary valve, the surgeon will remove some of the heart muscle in this area. This improves the flow of oxygen-poor blood from the right ventricle to the lungs. To fix the ventricular septal defect, the surgeon will cover the hole with a patch. The patch prevents the mixing of oxygen-poor blood with oxygen-rich blood. As a result, only oxygen-rich blood flows out of the aorta to the body from the left ventricle.
So this is about a tetralogy of Fallot. Second is transposition of the great arteries that causes right to left shunting. It produces ventriculo-arterial discordance. So aorta lies anterior and arises from the right ventricle, and the pulmonary artery is relatively posterior and arises from the left ventricle. And the outlook for the infants with TGA depends on the degree of blood mixing, the magnitude of tissue hypoxia, and the ability of the right ventricle to maintain the systemic circulation. So the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. This is a picture of transposition of the great arteries with ventricular septal defect and without ventricular septal defect. Switch operation is a type of operation in which the pulmonary artery and aorta is switched in between the right ventricle and left ventricle. Tricuspid atresia is also actually one of the causes of right to left shunt. It represents the complete obstruction of the tricuspid valve orifice. Third type of congenital heart lesions are obstructive lesions, and one of the type of obstructive lesion is aortic coarctation, which causes narrowing or constriction of the aorta. It is twice as common in males as in females. There are two classic forms. One is infantile form and second is an adult form. Infantile form, as the name suggests, it is symptomatic in the early childhood itself, and adult form is symptomatic in the adulthood. So this is coarctation of the aorta with patent ductus arteriosus and without patent ductus arteriosus. Coarctation means narrowing of the aorta. Clinical manifestations depend on the severity of the narrowing and the patency of the ductus arteriosus. So, if coarctation of the aorta is with the PDA, then it usually manifests in the early in the life. It may cause signs and symptoms immediately after birth. And if a coarctation of the aorta without PDA, then the aortic constriction, if is not severe, then it manifests in the adulthood. And the child, most of the children here are asymptomatic, and the disease may go unrecognized until adult life. Pulmonary stenosis and atresia are types of outflow obstruction with relatively frequent malformations. These are frequent malformations leading to obstruction at the level of pulmonary wall. Aortic stenosis and atresia are also forms of outflow obstruction. Narrowing or obstruction of the aortic valve at any location like valvular, subvalvular or supravalvular location. So, this congenital heart disease represents defects of cardiac chambers or the great vessels. There are three different types of congenital heart disease. One is left to right shunt, one that causes left to right shunts, second that causes right to left shunt, and third is that causes outflow obstructions. Left to right shunts are the most common types and typically associated with atrial septal defects, ventricular septal defect, or a patent ductus arteriosus. These lesions result in the chronic right-sided pressure and volume overloads and eventually causes pulmonary hypertension and reversal of flow, so right to left shunt and cyanosis. So this reversal of flow and ultimately right to left shunt with cyanosis is called as Eisenmenger syndrome. Second type of congenital heart disease, right to left shunts, are most commonly caused by tetralogy of Fallot or transposition of the great arteries. These are cyanotic lesions and also associated with polycythemia, hypertrophic osteoarthropathy, and paradoxical emboli. Third type of congenital heart disease are obstructive lesions like aortic coarctation and pulmonary stenosis, aortic stenosis, and atresias. So thank you. This is all about the congenital heart disease.